Thank you for introducing me, Professor Morinaga. Today, I want to have a presentation about current status of ESBL producing Enterobacterales infections and antimicrobial treatments, especially for epidemiology and antimicrobial treatments in Japan and overseas. I focused on compare with them in this presentation. This is my COI, nothing declared for this presentation. In 2013, CDC published a report outlining the top 18 antimicrobial resistant pathogens threats to the United States. 8 of them were gram-negative pathogens. Then ESBL producing Enterobacterales was classified as a pathogen at the second highest urgent level. Then Enterobacterales in large family of gram-negative bacteria that includes many of more familiar pathogens such as Salmonella, Escherichia coli, Yersinia pestis, Klebsiella, and Shigella, Proteus, Enterobacter, Serratia, and Citrobacter. Several are present in the human intestinal tract that cause 84 to 87% of urinary tract infections, 42 to 61% of biliary tract infections, and 72 to 89% of gram-negative bacteremia, increasing antimicrobial resistance, including resistance to broad-spectrum cephalosporin and carbapenem resistance, associated with poor clinical outcome, has been associated with increased mortality, hospital readmission, and cost. This slide shows clinically important beta-lactamases produced by select gram-negative bacteria. Enterobacterales have the majority of clinical important beta-lactamases producing gram-negative bacteria. Then E. coli, Klebsiella species, and Proteus mirabilis are major ESBL producing pathogens. This slide shows the number of ESBL carriers in the community in 2010, according to WHO region grouping. Strikingly, over 1.1 billion ESBL Enterobacterales carriers appear to be present in the community populations of Southeast Asia. The Western Pacific and Eastern Mediterranean regions rank second and third, with 280 and 180 million carriers, respectively, ahead of Africa, where 110 million carriers are estimated to be present. America and Europe appear to be so far behind, with 48 and 35 million carriers, respectively. This graph shows ESBL carriers rate in the community according to their geographical and temporal distribution. Over study period, ESBL producing Enterobacterales increased significantly in all regions, with differences within regions. From 2010 to 13, a total of 9,000 and about 600 isolates of gram-negative bacteria causing urinary tract infections were collected from 13 countries in Asia-Pacific regions. The yearly isolation rate of ESBL producing E. coli isolates were grossly highest in China, followed by Thailand, Hong Kong, Singapore, and South Korea. High rate of ESBL producing Klebsiella pneumonia isolates were observed in Thailand, the Philippines, and China. Japanese nationwide surveillance of the antimicrobial susceptibility against pathogens from patients with complicated urinary tract infections was conducted from 2007 to 8, 2010 to 11, and 2015 to 16. Comparing other Asia-Pacific countries, the yearly isolation rate of ESBL producing Enterobacterales in Japan has been relatively low. Isolation rate of ESBL producing E. coli was 24.3%. Klebsiella pneumoniae was 7.7%. And Proteus mirabilis was 10.9% in 2015. The proportion of ESBL producing E. coli and Klebsiella pneumoniae strains increased from the previous surveillance reports. Previously, TEM and SHV type enzymes had been the most predominant ESBLs worldwide. In the early 2000s, reports suggested that CTXM producing isolates were becoming widespread in Europe, Latin America, and Asia Pacific region. Later, this shift in the ESBL population towards higher number of CTXM producing isolates was observed. Between 2001 and 12, 100 over ESBL producing E. coli isolates were collected at 10 Japanese acute care hospitals. Increasing trend in the prevalence of ESBL producers with a prevalence of 0.2% in 2001, rising to 9.5% in 2012 amongst all E. coli isolates. CTXM type ESBL show higher detection rate compared to TEM and SHV type in Japan. The recent increase in ESBL producing E. coli from Japan resulted from emergence of a ST131 subclade with BURA CTXM27. Performed whole genome sequencing for 43 Japan and 10 global ST131 isolates to investigate the possible expansion of a single clade. The C1M27 clade is contributing to the global success of ST131. E. coli ST131 C1M27 poses a major new public health threat because of its global distribution and association with very dominant C/H30 linkage. In addition, Chen et al. Investigated the co-occurrence of plasmid-mediated AMP-C beta-lactamase ESBLs among carbapenemase negative E. coli and Klebsiella pneumoniae in different countries. Among Enterobacterales isolates causing intra-abdominal infections from 2015 to 18 in Asia Pacific region, 832 Enterobacterales isolates from 8 different countries with beta-lactamase gene were analyzed. E. coli with AMP-C and ESBL's positive gene was more prevalent in Taiwan and Vietnam. The most common combination among E. coli isolate was the CMY/CTXM type, followed by the DHA1/CTXM type. Among Klebsiella pneumoniae isolates, those from Taiwan represented the majority of co-occurring isolates with various AMP-C and ESBL combinations. This is part of the conclusion of epidemiology. In Japan, comparing other Asia-Pacific countries, the yearly isolation rate of ESBL-producing Enterobacterales in Japan has been relatively low. This slide shows typical antimicrobial susceptibility against ESBL-producing Enterobacterales. ESBL-producing Enterobacteriaceae have various antimicrobial susceptibility profiles due to gene type 10, SHV, or CTX type. Chang et al. Investigates the in vitro susceptibility rate of common organisms isolated from commonly associated, community-associated, and hospital-associated intra-abdominal infections, including a total of 17 over 1,000 isolates were collected from 54 centers in 13 countries in Asia-Pacific region. They found amikacin, ertapenem, and imipenem were the most effective agents against ESBL-producing isolates. Piptazole displayed good in vitro activity over 90% against community-associated ESBL-producing E. coli. Similar nationwide survey was conducted in Japan. All 504 isolates were collected at 26 institutions and referred to a central laboratory for susceptibility testing. Consequently, among Enterobacterales, 24.1% of E. coli strains, 14% of Klebsiella pneumoniae strains, and 0% Enterobacter cloacae strain produced ESBL. Meropenem, piptazole, cefmetazole, flumoxif, amikacin, and tigecycline showed over 90% susceptibility rate. In a nationwide survey was conducted in Japan from 2014 to 15 to investigate the antimicrobial susceptibility of pathogens isolated from surgical site infection. High level of susceptibility to ESBL-producing Enterobacterales were observed for meropenem, piptazole, and cefamycins, cefmetazole, and cefkistin. In addition, if the CLSI breakpoint for cefkistin was applied to flumoxif, which is classified as an oxacem, it is a local drug, the susceptibility rate was 90.2%. Additionally, my staff investigate the susceptibility profiles of ESBL Enterobacteriaceae isolates against various antimicrobials focused on E. coli, Klebsiella oxytoca, Klebsiella pneumoniae, and Proteus mirabilis. Consequently, ESBL-producing Enterobacteriales were highly susceptible to carbapenems and aminoglycosides, amikacin. ESBL-producing Enterobacteriales have various antimicrobial susceptibility profiles. In the global surveillance program, evaluated a total of 90,000 over isolates of Enterobacteriales, ESBL positive Enterobacteriales showed relatively higher susceptibility to colistin. In the global surveillance program, evaluated a total of about 2,000 gram-negative organisms from 14 medical centers in APAC regions. 25.6% exhibited an ESBL non-CRE phenotype. Cephalosporin and tazobactam showed good activity against ESBL non-CRE phenotype strain of Enterobacterales. In Japan, the efficacy and the safety of tazobactam cephalosporin in patients with complicated IAI were evaluated. Then, although bacterial number was limited, cephalosporin and tazobactam showed higher susceptibility against ESBL positive E. coli isolates compared with the other non-carbapenem antimicrobials. In total, 80 ESBL producing, non-KPC producing clinical Klebsiella pneumoniae isolates were collected in 12 hospitals from 2010 to 13 in China. Decreased susceptibility to hostomycin was particularly notable. Analyzing beta-lactamase among Enterobacterales isolates, 800 over Enterobacterales isolated from 8 different countries with beta-lactamase gene, and also the excellent inhibition by amikacin 80% and cholecystine 100% were observed. Susceptibility to carbapenems varied among different ESBL plus AMP-C combinations. Carbapenems remain active against CMY/CTXM type with a susceptibility rate greater than over 90%. However, the susceptibility rate decreased to approximately 70% in E. coli harboring DH1/CTXM. Susceptibility to amikacin decreased among isolate positive for both DHA1/CTXM or even combinations of 3 different beta-lactamases, such as DHA1, SHV, and CTXM. This slide shows a key point of ESBL Enterobacterales antimicrobial susceptibility. In Japan, high level of susceptibility were observed for meropenem, piptazole, and kefamycins. In addition, if the CLSI breakpoint for cefokistin was applied to flumoxif, which is classified oxacem, the susceptibility rate was 90.2%. ESBL producing Enterobacteriaceae have various antimicrobial susceptibility profiles. In Merino trials, this is very famous trial, is randomized clinical trials, effect of piptazole versus meropenem on 30-day mortality for patients with E. coli or Klebsiella pneumoniae bloodstream infections, and ceftriaxone resistance was evaluated. Phenotypic ESBL production was confirmed in 86% of isolates. Among patients with E. coli or Klebsiella pneumoniae bloodstream infections and ceftriaxone resistance, definitive treatment with piptazole compared with meropenem did not result in the non-inferior 30-day mortality. Secondary analysis reveals that although there was not significant difference, meropenem showed preferable secondary outcome in clinical and microbiological success at day 4. Also microbiological success at day 4. Microbiomes relapse secondary infection with multi-resistant organisms or Clostridioides difficile compared with piptazole therapy. In other clinical study, including 213 patients with monomicrobial ESBL bacteremia, they compared 40-day mortality in patients who all received piptazole versus carbapenems as empiric therapy and carbapenems as definitive therapy. Consequently, piptazole appeared inferior to carbapenems for the empiric therapy of ESBL bacteria. In the prospective randomized open-label comparison of the therapeutic efficacy of piptazo, kefpim, and ertapenem in the febrile nosocomial urinary tract infections with ESBL-producing E. coli, after the recruitment of 6 participants assigned to kefepim treatment group was stopped because of the unexpectedly higher treatment failure rate. Piptazo is effective in the treatment of UTI by ESBL E. coli when the in vitro test indicates susceptibility. Kefepim should not be used as an alternative treatment for urinary tract infections caused by ESBL E. coli. In Japan, retrospective study investigated 35 bacteremia patients with bacteremia caused by ESBL producing Enterobacterales treatment treated with piptazo monotherapy showed piptazo MIC 8/4 microgram per ml showed significantly higher microbial and clinical efficacy compared with that of MIC 16/4 microgram per ml reported by my colleagues. These results suggest that 8/4 microgram per ml piptazo MIC is recommended as a breakpoint of bacteremia caused by ESBL producing Enterobacterial assays in Japan. Although the current CLSI breakpoint is also useful. In retrospective analysis to identify risk factor mortality in patients with Phlomoxef susceptible ESBL Klebsiella, ESBL producing Klebsiella pneumonia, especially addressing the therapeutic roles of Phlomoxef carbapenem. Phlomoxef might be as clinically effective as a carbapenem in treating Phlomoxef susceptible Klebsiella pneumonia bacteremia. In another retrospective trial, the 30-day mortality rate for patients in ESBL, sulfametazole, and Phlomoxef, ESBL carbapenems, and non-ESBL sulfametazole and Phlomoxef groups were retrospectively 7.7%, 8.9%, and 3.0% respectively. Sulfametazole and Phlomoxef therapy may represent an effective alternative to carbapenem treatment for patients with ESBL producing E. coli bacteremia for empirical and definitive therapy in adult patients. Additionally, sulfametazole may be effective given to patients with bacteremia caused by ESBL producers as a definitive therapy, because the group that received carbapenem therapy had increased severity in the pit bacteremia score that the group received sulfametazole therapy. And 5 patients in carbapenem group and 1 patient in sulfametazole group died during the observational period. In children with pyelonephritis caused by ESBL producing Enterobacterales without bacteremia, retrospective observational study showed there was no significant difference in clinical cure rate. In 29 patients with pneumonia from ESBL producing bacteria were isolated from sputum, no significant difference was found in therapeutic effect of penicillins with beta-lactamase inhibitor and sulfametazole against pneumonia caused by ESBL producing bacteria. A multi-center retrospective study included in all adult patients treated with ceftriaxone tazobactam for any confirmed infection produced by ESBL producing Enterobacterales. Data showed ceftriaxone tazobactam could be a valid option in empiric and/or targeted therapy in patients with severe infection caused by ESBL producing Enterobacterial assay. the efficacy and safety of ceftriaxone tazobactam in Japanese patients with compared IAI were evaluated by us. Also, bacterial number was limited. Ceftriaxone tazobactam showed higher clinical efficacy against complicated IAI due to ESBL positive E. coli. This is the summary slide. In Japan, key antimicrobials for ESBL infection are carbapenems, aminoglycosides, cefmetazole, flumoxef. 8/4 microgram per ml piptazole MIC is recommended as a breakpoint for bacteremia. Cefmetazole and flumoxef therapy. That flumoxef is flumoxef is local drug in Japan. May represent an effective alternative to carbapenem treatment for patients with ESBL producing E. coli bacteremia for empirical and definitive therapy in adult patients in Japan. Thank you for your attention.
Professor Mikamo, thank you very much for wonderful presentation. Now we have a few minutes for open question and comments. Do you have any questions from the audience? Okay, can I ask a question?
Okay.
Okay. You mentioned that comparing to Asia countries, Japan has relatively low prevalence of ESBL producer, but their continuous increase. To suppress the increase of ESBL producers, what is the most important point we should focus on, such as the best use of antimicrobial?
Yeah, Professor Morinaga, thank you for your one good question. However, I wonder, we wonder about lower rate of ESBL producing Enterobacterales compared with Asian countries, especially in China and Korea and also Taiwan, and including Thailand. Probably in Japan, as you may know, the infection control measure is superior compared with other Asian countries. That is reason not prevalent of ESBL producing bacteria all over Japan compared with other countries. That is only speculation. However, the details is not clear.
Okay, thank you very much.
Thank you.